So the first question is, which site of facial defect correlates with most commonly a lateral cystocele? Now, when I say that there is something called as a lateral cystocele, I am not sure if you all know what a lateral cystocele is. Now, lateral cystocele is also one of the mentions where, or one of the places where I've mentioned it happens to be for lateral cystocele happens to be in the chapter of prolapse in POPQ discussions. So one of the shortcomings of POPQ is that it cannot measure or it cannot quantify SEY, and the other one is it does not have any value for lateral cystocele. So what is lateral cystocele? Imagine that you have a female in a lithotomy position. This is, of course, then going to be her anterior, and this is going to be her posterior when she's lying down in lithotomy position. This is going to be her right side, and this is going to be her left side. So anterior, posterior, right and left. Of course, these are her legs. Let us assume these are her legs. And then I am now going to magnify the vagina. So when I magnify the vagina, I'm going to get, first of all, four walls. Those four walls include my anterior wall, above which I have my urinary bladder, the posterior wall behind which I have my rectum, and the lateral walls where I have my endopelvic connective tissue. Endopelvic connective tissue is just a connective tissue that keeps all the pelvic organs in their place and doesn't let it move. Now, all these pelvic organs, or these three major organs that we have, the rectum, the bowel, the bladder, the bowel, and of course my uterus, cervix, and vagina, all of them have to be kept in their place because excessive mobility is going to lead to anterior-posterior mobility is going to lead to what do I call it? Instability. Now, this instability is going to be a reason why we can have an early onset of prolapse. So, to prevent this prolapse, there is this cotton-like, it is like how you keep your fruits, your perishable fruits like mangoes in hay or dried grass. Similarly, just like cotton, literally like cotton, it looks also like cotton when you operate. You can see it very often whenever you're doing in your LSCS, whenever you are separating your UV fold. The layer between your utrovesical or your visceral peritoneum fold and your uterine lower segment, you can see there are very thin cotton-like cotton-like substance that is seen, and that happens to be your endopelvic fascia. So that is present throughout your pelvis, which helps in stabilizing it. So the yellow thing that I've made over here is that endopelvic fascia. The one that is there between my bladder or my pubic symphysis, if I'll just make my pubic symphysis with a black pen over here, this is my pubic symphysis. And posteriorly, I have my bigger sacral promontory. So between my pubic symphysis and my cervix over here or my vagina over here, this anterior part is roughly called as, or this part, this tissue is called as pubocervical fascia. The part between the vagina and the rectum, just this one, is the Denon-Villiers fascia. And the entire thing, if I'm going to classify it between this to this, is the puborectal fascia. And if I'm going to combine all of them or give a complete or a single name to them, we call it the endopelvic connective tissue. So this is how it looks like, and this is how it is going to be there inside. Now, we of course know that whenever the bladder is going to come in between, now if this endopelvic connective tissue that is present between the bladder and the vagina, if it gets depleted, and it will get depleted because of various reasons. So imagine that this gets depleted from here, the way I depleted it now. In that scenario, my bladder is going to push upon the anterior wall of my vagina and is going to lead to something called as a cystocele. Similarly, if this over here, the area between my rectum and my vagina posteriorly is going to get reduced, then that will lead to the rectum and posterior vaginal wall coming too close, and that will lead to a rectocele. We have already known all of these things. What is a cystocele? What is a rectocele? It is basically the protrusion of vaginal walls into the vaginal vault because of the depletion of this endopelvic fascia and thinning of the vaginal walls. Now, this is going to happen mainly because of menopause, because all these endopelvic fascia, all this endopelvic fascia contains a lot of estrogen receptors in it like this. These estrogen receptors, when they do not receive estrogen, which is going to be after menopause, that will lead to gradual depletion and thinning of the endopelvic fascia. So if it gets thinned out, the possibility and the chances of prolapse occurring increase, which is why we often see prolapse in elderly women. Secondly, because of multiple childbearing or because of obstructed labor, when the vaginal wall is getting distended, because of the distension of the vaginal wall, because of the fetal head and the process of labor in general, this endopelvic fascia gets compressed and it leads to necrosis of that pelvic fascia. And because of that necrosis or thinning out of that fascia, because of the pressure from the fetal head and the vaginal wall, again it gets depleted, which is why high parity, if a female has had multiple vaginal deliveries, or if the female has had any history of obstructed labor or prolonged labor, in that scenario, these women are also going to be at a high risk. These are actually the risk factors for pelvic organ prolapse. So these women are at a high risk of getting prolapse at a later age. So these are the risk factors, which includes your age, your menopausal status, your multiparity, obstructed labor or prolonged labor, macrosomic baby, are the commonest reasons why prolapse occurs in women. Now we have studied about this anterior-posterior relation, but what if this lateral parametrium, this lateral tissue also presses upon, now laterally you have all your musculature, your levator ani and everything. So what if the lateral parametrial tissue also compresses and pushes the vaginal walls medially? This will lead to something called as a lateral cystocele. Just like you had an anterior cystocele because of the bladder, there can be a lateral cystocele. And we call it cystocele only because when the bladder is going to be distended, a distended bladder is going to be on three sides of the vaginal wall. And this is not only going to compress anteriorly but also laterally. And hence, when that bladder is also coming into the vagina through its lateral walls, a distended is basically a urine-filled bladder. That is going to be called as a lateral cystocele. Now, obviously, we know that the repair for anterior cystocele or the normal cystocele that we have studied until now is anterior colporrhaphy, wherein what do? We open the anterior vaginal wall. So I'll just remove all these things that I've just drawn so that it becomes easy for me. Now, we of course know that whenever I have to do a repair, now imagine that I'm looking at this bladder, and on this bladder, I have my vaginal wall. Now I'm looking at it in this way. So basically, now I'm seeing it from this view, like this. I'm seeing it like this. When I'm seeing it, the way I do anterior colporrhaphy is I open the vaginal wall, I expose the bladder, I take multiple stitches over there. So basically, whatever, when I see this anterior vaginal wall like this, when I'm seeing it like this, or now, right now, I was seeing it with the female lying and I was seeing it like this. Now, when I see the anterior wall, if I'm going to see the anterior wall, on that anterior wall, when I give an incision in between, I see that the bladder is present over there. Of course, the bladder is present over there. But more than the bladder, I see that the endopelvic fascia has suffered multiple tears or it has become thinned out. So what I do is I take a suture material and I pass the suture material from all these endopelvic fascias and I tie it in between. So basically, I'm bringing together whatever little tissue endopelvic fascia is left. I bring it together with the help of stitches. This is called as anterior colporrhaphy. Colpo is vagina, raphy is repair. Repairing the anterior wall of vagina this way is called as anterior colporrhaphy. So obviously, when I'm pulling this tissue in between, the vaginal wall also gets pulled in between, and there is a bit of redundant vaginal wall that is left, and that vaginal wall or the vaginal mucosa is resected off. This resection and this plication of endopelvic fascia together reduces the cystocele. Now I can easily do this repair on the anterior wall, but on the lateral wall, it is a little difficult to do that. It is difficult to do that not just because accessing the lateral areas is a little more difficult, but also because in the lateral wall, I may have the ureter, I may have the uterine artery or the descending cervical artery. So for that, I have to do it under visualization. And for visualization, what I do is going to be a paravaginal repair. Paravaginal repair is basically going to be, I do the same thing, but I pull this vaginal vault outside. I pull it outside like this because it had collapsed on the inner side medially. To repair it, I pull it laterally outwards and I attach it to a fibrous structure on the lateral wall called as arcus tendinous fascia pelvis. Now, what is this arcus tendinous fascia pelvis? I'll show that to you right now. This arcus tendinous fascia pelvis is actually the lateral attachment of that cotton that I had told you all. Endopelvic fascia जो है उसका lateral attachment है. Now if you see over here, this picture, okay. Now over here you see that this part, this fibrous part is called as the arcus tendinous fascia pelvis. So basically this fibrous part that is seen laterally is going to attach on both the sides the endopelvic tissue like this. It is going to be attached to this. And medially, it is going to be attached to all the organs that I've mentioned. So basically, what I'm doing now is this uterus, I am taking a stitch from here and I'm putting it over here. So basically, I'm taking stitches like this. This, because is lateral, that is to the side of my vagina, is called as a paravaginal repair. And this paravaginal repair, this is your vagina, of course, is going to help me reduce this lateral cystocele where the wall had fallen medially by again pulling it back outside. And hence the repair for lateral cystocele is going to be paravaginal repair, and the cause of that lateral cystocele was the lateral detachment at arcus tendinous fascia pelvis. Did everyone understand this surgery for lateral cystocele? Now, this is something that is a very high grade core concept which is not often asked in your theory or practical exams, which is why I had not mentioned it during the original lecture, but in your MCQs, it is an important concept, and hence I have mentioned it. Before I proceed, quickly tell me if you all have understood this concept. Have you all understood this concept? Any doubts whatsoever? Please quickly tell me so that I can proceed. Ruchika, Rashmi, Karishma, Geeta, Tejaswini, Amira, Anita. Quickly tell me if you all have understood so that I can move ahead. This was a bit of a complex concept. Have you all understood this concept right now? Karishma, okay, great. Karishma, are you a new joinee? Because I think I'm seeing your name for the first time. Excuse me if I've not noticed you before. I keep a track of all the students. Arcus tendis once more. Don't think much about it. What is arcus tendinous? You know your arcuate line is there in the at the pelvic inlet. Your arcuate line is present on the pelvic inlet. It is formed by all the bones at pelvic inlet. On it, there is a fibrotic attachment of your endopelvic. Imagine that your cotton, of course, it needs to be adhered somewhere. It needs to be stuck somewhere. The cotton which I was saying was the endopelvic fascia. It has to be stuck somewhere so that it is stable. So it is stable, of course, just like every muscle has an attachment and has an origin and an insertion. So think of it that way, that this endopelvic fascia has an origin on the arcuus tendinous fascia pelvis. It's just a fibrous structure where the endopelvic fascia is adhered. And medially, it is inserted onto the organs which includes your rectum, vagina, and your bladder. Nothing else. So the lateral attachment is called as arcus tendinous fascia pelvis. The same attachment for the levator ani is called as arcuus tendinous levator ani. It is basically the levator ani's attachment to the lateral pelvic wall. Did you understand it now? It is nothing but a fibrotic attachment of endopelvic fascia laterally onto the pelvis. When it is torn, it is going to get medially, the endopelvic fascia is going to retract medially and is going to result in a lateral cystocele. Okay, great. Got it. So moving on to the next question. By the way, the difficulty level also has been given over here. It is stated to be of the hard difficulty level. Next. The next question is Purandare's cervicopexy differs from Shirodkar's sling surgery primarily in which way? Now, before I move to Purandare's cervicopexy and to this question, I would want to tell you all what is Purandare's cervicopexy and what is Shirodkar's sling surgery. Now, now imagine that I'm taking a transverse cross section of my pelvis. So when I take that anteriorly, I have my, I'll just draw it a little on the left side. So anteriorly, I have my pubic symphysis. Posteriorly, I have my bigger sacral promontory. So this is my anterior end. This is my posterior end. Over here, I have my three organs, which happens to be my bladder, my uterus, and my bowel. Rectum बोलो या फिर sigmoid colon बोलो कुछ भी चलेगा. But these are the organs that are present over here. Now, I'm not going to draw my endopelvic fascia because I'm not going to do anything about it. One ligament that you have to know about over here is I have my deep inguinal ring that is situated over here on both the sides, and from the uterus, something called as what you will tell me goes into the deep inguinal ring and then comes out through the superficial inguinal ring inside the labia majora. What is this called as? You all tell me in the comments in the chat section. Quickly tell me. It is very important to understand during Purandare's repair. Now, Purandare, Shirodkar, Khanna, Virkud, all these surgeries, Joshi, all these surgeries are done only and only for young women who wish to preserve their fertility. And when I say young, it is usually less than 40 years of age. It can also be done in much younger patients, of course, because I have to conserve their I have to conserve their uterus. Inguinal ligament, no, that's a grossly wrong answer. Yes, correct, it is the round ligament. Inguinal ligament is attached from the pubic symphysis to the anterior superior iliac spine. It is just a condensation of the lower end of rectus muscle. It has nothing to do with the uterus. So it is not the inguinal ligament, it is the round ligament. Okay, so where was I? Huh. So this surgery or these surgeries, all the sling surgeries are only and only done for what I call as they are done for young women who wish to conserve their fertility. Now, when they wish to conserve their fertility, I cannot remove the uterus, so hysterectomy is out of question. So, what can I do is the uterus that has gone down, which has gotten prolapsed, I can again pull it up and I can put it in place by taking a stitch around the uterus to hold it in its original location. Now, these surgeries or this stitch is called as a sling surgery. Obviously, I cannot take an absorbable suture material यहाँ पे because if I take an absorbable suture material, then once it gets absorbed, the prolapse will again recur, and I do not want a recurrence because the female is very young and she has a lot more years. She probably has double her age to live even now, and hence I cannot. I wouldn't want a recurrence or a relapse of a prolapse, which is why the material that I use is a Mercilin tape, not a mesh. Remember, mesh is not used for this surgery. What we use is a Mercilin tape. So when I use a Mercilin tape, I have two ways in which I can attach it. I can either attach it anteriorly, the tape, or I can attach it posteriorly, or I can even attach it laterally, but that is a surgery that is not commonly done. So in Purandare's surgery or Purandare's cervicopexy, Dr. Purandare, what did he say? He said that I will put a stitch on the uterus. So basically, if this was my uterus and this was the isthmus, isthmus is basically the area between the uterus and the cervix. So if this is my cervix and this is my uterus, this isthmus. So he said that at the level of isthmus, I'll take a Mercilin tape and I will attach it over here at this isthmus. This isthmus, or I can even take it a little lower into the cervical level. I will take this stitch over here. I'll put a suture on this, a permanent suture on this so that it gets adhered over here. And then anteriorly, I'll put this tape which is attached, I will put it onto the rectus muscle. So I have anteriorly my rectus muscle, which is present on the abdominal wall. So over here, I have my rectus muscle. So over here, rather the rectus muscle, the rectus sheath, which is present in front of the rectus muscle. So if this was my rectus muscle and this was my rectus sheath, they said that I will take this suture over here, this sling over here, and then again put a stitch over here. So I took three stitches, one on the isthmus and the cervix, the other one, or the other two in fact, onto the anterior rectus sheath. So by this way, I pulled the uterus up, because remember that if your uterus is here, your rectus muscle is going to be much higher up. Your rectus muscle is going to be much higher up over here. Which is why when you put, these are your two rectus muscle, you of course have two rectus muscle, in between you have your linea alba. So when you take a stitch onto this, of course the uterus is going to be pulled upwards. This way, the uterus was getting pulled upwards, but there was one small problem that was occurring, and that was the uterine cervix was getting pulled anteriorly. So if I'm now going to see it from a lateral point of view, I'll just erase all of this now. So if I have to see this surgery from a lateral point of view, and if this was my pubic symphysis, this was my sacrum, this was my bladder, this was my normal but prolapsed uterus, and the vagina, this is the vagina, this is the cervix, this is the uterus, and over here I have my rectum. So in this case, what was happening was, this was my rectus muscle and the rectus sheath in front of that, this rectus sheath. So I was taking this suture from this cervical junction and attaching it over here. Because of this normal uterine anatomy, which was usually anteverted, my uterus normally was anteverted. After this surgery, the uterus was becoming something like this. Because of that stitch that was being taken anteriorly, it was being pulled anteriorly, the uterus was becoming retroverted. Now, because of this retroversion, there were two problems that were occurring. A first problem was this endopelvic fascia that was present between the uterus and the rectum, what we also call as the denonvillous fascia. This denonvillous fascia, because it was getting pulled anteriorly, this denonvillous fascia was getting torn. So this was my denonvillous fascia, this was my uterus over here. This denonvillous fascia was getting torn because the uterus was being pulled anteriorly. And when the denonvillous fascia is being torn, I of course know the complication is going to be the rectum will start coming into the vagina and will lead to rectocele. So over a period of time, these women were developing rectocele. Apart from that, because of the retroversion, the sperms were finding it difficult to reach the fallopian tubes, and the whole purpose of the surgery, to which used to be to conserve the fertility, was instead degrading the fertility even further because of the retroversion. So it was not really helping the fertility part, though it was helping the prolapse part, and hence Dr. Mhatre decided to do a modification of Purandare cervicopexy, and that was called as round ligament plication. So what they said was, this round ligament that I've shown you over here, this round ligament on both the sides, what they said was, what we'll do is we'll reduce the length of these by putting multiple sutures on them. Basically, we call this plication. So, itna bada jo tha round ligament, because of the suture, it was reduced to this length, and that reduction pulled the uterine fundus anteriorly, and hence the uterine anteversion was again restored. Why was it restored? Because the round ligaments now were shortened due to the sutures that were taken on them. This is called as Purandare cervicopexy with round ligament plication. Hence, this is how you retained the anteversion, you avoided the rectocele formation, and also corrected the prolapse. This was Purandare cervicopexy with round ligament plication. Now, this had a few problems. The problems were, the abdominal wall loses its tone. The abdominal muscles lose their tone after every pregnancy. So if this female would have already had a pregnancy before, her abdominal wall tone would have already been poor, or if she conceived after this, then her abdominal tone would become poor after that pregnancy. Eventually, what would happen is because of weakening of the abdominal wall and the abdominal muscles, this sling would become very lax. This laxity was because this was a dynamic sling. What do I mean by dynamic sling? Dynamic means that this was a movable sling. Why do I say so? Because whenever a female cuffs or whenever a person cuffs, you tighten your abdominal muscles. Try seeing it, try cuffing, and you would see that your abdominal muscles get pulled inside. They get very taut. Because of this, in a usual sense, the uterus would get corrected, the prolapse would get corrected even further. But if that same abdominal wall tone is lost because of pregnancy or because of obesity or anything else, then in that scenario, this dynamic sling would instead be a poor thing that is happening for this sling surgery, and the prolapse would not get corrected that well. Hence, this was a dynamic sling. It was an anterior dynamic sling, and hence this dynamic part was making the prolapse recur after a certain period of time. To take care of this, someone called as Dr. Shirodkar came in, and Dr. Shirodkar said that let me correct this sling into a static sling. A static sling is one that will never in her lifetime become weak because I'll attach it to something like I'll attach it to some such structure which will prevent it from getting loose ever again and is not going to be dependent on cuffing, obesity, and pregnancy. That structure was, quickly tell me in the comments what was the name of that structure until I draw the diagram. Quickly tell me, where did Shirodkar decide to attach his sling? I have explained it on multiple occasions, so quickly tell me that. Very good, Meena. On the sacral promontory or on the sacrum, you can say, and to be more particular about it, you can say the anterior longitudinal ligament that runs on the center of the sacrum. So what he did was he took this sling and instead attached it over here. Now, the good part about this surgery was that it was a static sling because it wouldn't move. It is attached to a bony structure. And secondly, this was a posterior sling. So the anti version of the uterus was getting maintained. So if this was my uterus, the anti version was getting retained because it was a posterior sling like this. Hence, the fertility was also not affected. It didn't move with cuffing, obesity, and pregnancy. And it was a good surgery, but there was one small problem. Both these slings, if you can see, are a closed loop. You can see that it forms a completely closed loop. Over here as well, it's a completely closed loop. Anteriorly, that was not causing much of an issue, but posteriorly, the bowel loops were getting entrapped in it. And because these bowel loops were getting entrapped in it, there was a chance of bowel strangulation that would occur. It's a rare possibility, but it can be a very morbid problem that is occurring. Secondly, the gynecologist said that we are not really comfortable going into the sacrum posteriorly, and the bleeding of the medial sacral vessels was so torrential that if pricked by mistake, it was very difficult to control its bleeding, because of which a new surgery came in place of Shirodkar and Purandare, which was called as Virkud's composite sling surgery. But this, by the way, was Shirodkar's sling surgery, which was a static posterior closed loop surgery. So, to combine both the benefits and advantages of the surgery, correct, half anterior, half posterior. So he said the Purandare, Dr. Virkud, who is still there, Dr. Ajit Virkud, a legendary surgeon, a legendary teacher. In fact, I wish that I rise to his level someday, or maybe half of it someday. A brilliant teacher and way ahead of his time. He was making videos on YouTube way before all of this online teaching and all was taking place. So what he did was he said that the same anatomical landmarks, pubic symphysis, sacrum, bladder, rectum, and uterus, of course. He said that the risk of bowel getting pricked was very high on the left side. Why on the left side? Because on the left side there was a sigmoid colon. See, he said that posteriorly, I will not take it to the left side. Instead, I'll take the sling onto the other side. So this way, he put it on the right side, and anteriorly, he put it on the left side. This, of course, anteriorly, he attached it to the rectus sheath again. So onto the rectus sheath, he attached it. So this was an open loop, dynamic plus static, and antero plus posterior sling. Because it was a combination of everything, this was called as Virchow's composite. Composite matlab mixture. Composite sling surgery. Very good surgery, effective surgery, and a good modification. So these are the three major surgeries that you need to know about. Sir, left anterior and right posterior. No, yes, correct. Left anterior and right posterior. So over here, by the way, we are seeing from up down. We are not seeing from downward up. I'm seeing it from an abdominal view, which is why this is my left side. In everything that I've spoken, this is my left side. This is my right side. Because on the left side, I have my sigmoid colon. So I'm seeing it from the abdominal. जो earlier example जो मैंने explain किया था in the first question, it was from a vaginal point of view, from a lithotomy position. Whereas right now I'm looking at it from the abdomen, which is why this is my left and this is my right. So left anterior and right posterior. So this was Virchow's composite sling surgery, and these are the three main surgeries that you need to know. Apart from that, there are a few other surgeries also that you need to know, and they happen to be Khanna's sling surgery and Soonawala's sling surgery. Very simple. It is more or less having same concepts. So in Khanna sling surgery, he said, मेरे को आगे का भी नहीं चाहिए, मेरे को पीछे का भी नहीं चाहिए. I'll do something else. So he said, I have two more bony anatomical points, and they happen to be my anterior superior iliac spine. So I'll take the sling and attach it to the anterior superior iliac spine. So this remains like an anterior repair. Again, anterior lateral, you can say. It is an open loop, so no risk of strangulation. And it is again a static sling. So anterior static sling, a very good thing, but there was a small problem because my anterior superior iliac spine was very close to my skin. It would lead to erosion of the skin and exposure of the sling material, which is my muslin tape. It was also leading to periostitis and excessive pain at the site of attachment of the muslin tape, which is why this surgery is not commonly done, especially because it gets eroded and gets exposed to the outer environment and eventually gets infected. Soonawala sir said that I'll do something more. He said that the sling surgery that I'll do would be just one-sided loop, only on one side, that is on the right side. He said, I'll just do this. I won't do anything more so that on the left side, I can spare the sigmoid colon. Unfortunately, because this was a unilateral surgery, the uterus will get pulled to one side and that would lead to tears on the other side in the endopelvic fascia. Just like in Purandares, there were tears in the Denonvillus fascia leading to rectocele. Over here, because there were tears on the other side, that is on the left side, it would lead to a left-sided lateral cystocele. But these are the five main surgeries that you need to know about in sling surgery. Young patient with prolapse. Did everyone understand this quick overview of this question? And hence, let us just answer this question. Purandare cervicopexy differs from Shirodaka sling surgery in. Does it differ in the approach? No, both are abdominal only. The use of round ligament, yes, the use of round ligament is done only in Purandare, so it refers there. Use of mesh, no, mesh is not used in both, and need for hysterectomy, absolutely not. It is in fact done to not do hysterectomy. So the answer is the use of round ligament is done in Purandare cervicopexy. Quickly tell me, सबको समझा क्या ये?